fellow warriors. Here we are with a short but interesting newsletter from the website prostatewarriors.com. Today's deep dive explores two major paradigms in prostate cancer care. First, we are looking at some cutting-edge clinical trials challenging how advanced cancer is treated. And second, we will take a comforting long-term view of localized treatments.
Yeah, and I want to set the tone right away for you. Whether you are looking at experimental trials or traditional therapies, knowledge is your greatest weapon. It is a serious topic, but, there is so much deep hope in this data.
Absolutely. But the main focus today is bipolar androgen therapy, or BAT. This strategy was pioneered at Johns Hopkins, right?
Yes, and advanced heavily by Dr. Emmanuel Antonarakis for MAPMR prostate cancer. That's metastatic androgen pathway modulation-resistant cancer.
Okay, let's unpack this. Traditional therapy starves the cancer of testosterone, but BAT does the exact opposite. It gives monthly intramuscular testosterone, like cypionate or enanthate, to reach supraphysiologic levels of around 1,500 NGDL. I mean, isn't that like throwing gasoline on a fire?
It completely sounds like it,
Hey.
but it actually exploits the tumor's dependence on an overactive androgen receptor.
Oh, so it uses the cancer's own adaptation against it.
Exactly. By rapidly cycling between a castrate state and massive testosterone levels, it just shocks the cancer cells. And the data shows PSA50 responses in about 30 to 40% of asymptomatic low to intermediate burden patients.
Wow, that's wild. What is the catch? I mean, this can't be for everyone.
Definitely not. There is a 10% risk of disease acceleration.
Oh, yikes.
Yeah, meaning B is heavily restricted to minimally symptomatic patients. So no bone pain needing narcotics and no impending urinary obstruction.
Makes sense. You need to be stable enough to handle a potential flare.
Right. And the biomarker data here is just fascinating. They use next-generation sequencing within 30 days of the first dose. AR amplification strongly predicts sensitivity.
Okay, that tracks with the mechanism.
But amazingly, pathogenic TP53 mutations, which are usually, a highly negative sign, they actually result in improved PSA50 rates.
Wait, really? A bad mutation actually helps here?
It does. And a combination of AR amplification and a TP53 mutation yields a massive, 70% PSA50 rate.
That is incredible.
It really is. But conversely, SPOP and AR-LBD mutations, like 875 or 878, those signal resistance.
Good to know. Well, moving from BAT, which is highly personalized molecular targeting for advanced disease, let's zoom out. What happens when we look at the big picture for standard localized prostate cancer?
This is where the 10-year data from the CEASAR observational cohort comes in. These are men diagnosed back in 2011 and 2012.
Right, and the takeaway is incredible. For favorable prognosis patients, the 10-year prostate cancer mortality rate is strikingly low. I mean, under 1.5% across all management approaches. Surgery, external beam radiotherapy, brachytherapy, and active surveillance.
It is such a reassuring number for patients.
It is. But here's where it gets really interesting. The data shows radiation and active surveillance have higher overall mortality than surgery. But wait, isn't that just a selection bias? Do healthier, younger guys just naturally opt for surgery?
Yes, exactly. You hit the nail on the head.
I figured.
Even sophisticated statistical models cannot erase the fact that healthier men get radical prostatectomies. The overall survival difference is residual confounding.
So it's not proof that surgery inherently extends life more than radiation for localized disease.
Exactly. Even in unfavorable prognosis cases, radiation showed worse overall survival, with a hazard ratio near 2.8. But there was no significant difference in prostate cancer-specific mortality once adjustments were made.
Wow, and this is backed by the Protector randomized trial too, right?
It is. So the ultimate takeaway here is when choosing between surgery, radiation, or surveillance for localized cancer, patients shouldn't stress over minor survival statistics.
Right, it shouldn't be driven by survival fear.
Exactly. The choice should be deeply personal, driven by life expectancy, comorbidities, and which side effects, urinary, sexual, bowel, that they're most willing to tolerate.
So wrapping this deep dive up, the landscape is shifting toward immense personalization. From exploiting specific tumor mutations with extreme testosterone cycling to making localized treatment choices purely based on personal quality of life.
Right. And I will leave you with a final thought to ponder. If standard treatments for localized cancer offer such similar long-term survival odds, how soon will we see the same kind of advanced genomic testing used in bat trials applied to localized cancer?
Oh, you mean testing to predict the side effects?
Exactly. Not to predict survival, but to objectively predict exactly which side effects a patient is genetically most likely to experience. Well, that wraps up our deep dive for today. Stay strong and fight on.